to the open forum, or otherwise the Q&A session, asking the experts. We have a lot of panelists that are going to be joining and available to answer some questions, as well as our Q&A panelist, who will be Deborah Shelton, that spoke earlier with ACPMP, and the moderator will be Dr. Lambert, just to organize questions and things like that. So some of our panelists that are going to be joining are Drs. Levine, Dr. Turaga, Dr. Lambert, who are appendix cancer surgical oncologists. We have Dr. Shergill, Dr. Rocha-Lima, and Dr. Soares, who are medical oncologists. We have Dr. McQuellon, who specializes in quality of life and can also talk upon COVID-19. We have Dr. Affolter with Huntsman, who is a pathologist, and we have Dr. Sarah Macaraeg, who's a physical therapist, and Dr. Jeffrey Whitridge, who's a dietitian. So the Q&A session will be an hour from 1:40 to 2:40. So we are going to try and get to as many questions as possible. Please note that it is an hour session, so there are some time constraints. And if your questions do not get answered, we encourage you to ask your specialized oncologist directly. Thank you so much, and we're going to kick it off.
Okay, great. Thank you, Lauren. So let me just start with saying that we got a lot of questions, which is fantastic. Happy to see so many of you so engaged, patients, caregivers. That's what this is about, is your opportunity to avail yourself of the significant expertise that we have the benefit of today. We received a lot of questions as part of the registration process, and then I see that many more have been coming in since, many of which have been coming in writing and being answered through some of our speakers. And so I believe that the questions and those answered will be made available following this symposium. But just so that you all are aware, as another thing you can try is if you kind of space over the bottom of your screen, you will see the Q&A. And if you click into it, you should see up top a tab in the middle says answered, and you'll see 23. So I'm not sure if all of you will be able to see all of the questions and answers, but I did want to call that to your attention. And we have an hour, and as Lauren said, we'll try to get to as many of the other questions as we can. So let me just start here. I've got my buckets and my chicken scratch I've been trying to keep up with during the presentations. So we have a few different buckets, and I thought, since we do have a kind of quality of life COVID expert here with us, we'd start with that as a bit of an icebreaker with a COVID question that, you know, we get quite a bit, which is, you know, for our ACPMP patients who are now post-treatment, whether that be post-CRS Ipac, and so maybe now they no longer have a spleen because the spleen had disease and was removed, or maybe they're finishing up their chemotherapeutic regimen. Are they at a greater risk of contracting COVID-19? And relatedly, what are some steps that maybe patients should be thinking about during the travel restrictions and some of the challenges with the pandemic to make sure that they're taking appropriate care of themselves in terms of getting the right communications with their specialists and just kind of staying on top of things?
Well, Deborah, I think that might be a good question to start with, maybe one of the medical oncologists. Dr. Shergill, or?
Okay.
Thank you.
Great.
Hi, I'm happy to take the question. So in terms of patients who don't have spleen or patients who are finishing chemotherapy, are they at higher risk for contacting COVID? What I tell patients is you are at higher risk for getting sicker with it. That's what the data has shown. Patients who have cancers on chemo or post-chemotherapy, they are sicker with COVID. So exercising, extra caution and all the caution that we all should be wearing masks, avoiding sick patients, sick members, hand washing, social distancing, all of that is even more important in our patients then. And that's how I've been advising patients.
Great. And then a related question that we did get in, and we see a lot of patients with a lot of stress, understandably so, is there, and maybe the answer is just do the best you can with video conferencing and phone calls. But is there any advice for how patients can overcome the fact that there are these travel restrictions and whatnot in terms of still being able to keep up good communications with their medical teams, or if they're trying to consult with different physicians prior to treatment about what their options are? Does anyone have any advice for that? Because a lot of nerves are frayed with some of those challenges.
Yeah, I think the travel restrictions are very significant, but fortunately, in our clinics, the video interface has been working really well. We've been able to see patients from across the country and advise. We get all the records and we're able to advise. Of course, there's some limitation. I can't examine. And so in the end, if there is a trial, if there's a treatment, they would need to come. But I think it helps quite a bit, and we can make it as efficient as possible in that setting. And so, that I would use it to our advantage, having a previous video visit to understand. I think lots of centers are doing that, to understand what the options are and then considering whether it's worth going there.
Great, terrific. So we have some causation questions. I think is someone, maybe it was Dr. Lambert and others did mention today, that's always kind of a common question. So maybe Dr. Lambert, I'll kick this one to you to start with, and of course anyone else that has input. But in terms of causation, we all want to know, like, what is known about what causes this? Is it, for example, hereditary? We've had a couple patients here that, one person has actually lost 2 children to ACPMP and is now worried about grandchildren. And so wondering if there's a hereditary component, or is there an environmental component? I think Dr. Lambert, you had mentioned that in your presentation. So specifically, we get questions about like chemicals, people that grew up near military bases and, or have fought in wars, Agent Orange. Is there something in the water? We get questions about, is there a relationship with Zantac, since that's been found to be potentially carcinogenic, talcum powder. What do we know about causation, if anything, or is there some research being done to really look at that? Because I think the thinking is, if we know about that, then maybe we can know something about how to prevent this.
Yeah, I agree. I hear this question all the time. I'm sure Dr. Turaga and Dr. Levine hear it as well. Dr. Eng, I think one of to state the obvious, the big challenge is that this is a rare tumor. As best we know, I saw that question and I was, somewhat surprised to hear that a family had been affected that much by appendiceal cancer and pseudomyxoma. I've not seen that in my practice with all the people that I've taken care of. I've not had any, first degree relatives that have had it. Maybe Dr. Levine, Dr. Turaga, Dr. Eng can comment on that. But to our knowledge, this isn't associated with a germline mutation that's inherited. I often tell people that ask me this question, when they ask, is it something that's inherited? I say, I wish it was, right? In the sense that, like you said, Deb, if we could identify people who are at risk, we could take out their appendix, right? And wouldn't that be wonderful to have a whole day in the operating room of doing prophylactic appendectomies to, and patients who are people who are at high risk of getting appendiceal cancer. But unfortunately, we don't know that. And just like you've said, I've heard all the same things. I worked with depleted uranium. I've been a hairdresser my whole life. I lived in this part of the country. We just don't know what's causing it. I suspect that as we are seeing this increase in the incidence, and if we are starting to identify hotspots, I know that there have been places that have been considered hotspots. We might be able to put a finger on something. But unfortunately, at this point, I am not aware of an obvious cause. I suspect it's going to be multifactorial. It may be related to the use of or Zantac, in the sense that I know Dr. Sardi is doing the study looking at the role of H. pylori. Could it be some sort of bacteria, microbiome, diet? Dr. Whitridge is here about his dietitian. I'm sure he gets asked these questions all the time. But I'll throw it out there to Ed and Karen and Oliver. Do you guys have any other thoughts on, do you guys know something that I don't know?
No, Laura, I think that's well summated. I think we're all struggling with the same thing. I would only appeal to the patient who actually reported familial history of appendix cancer. I think it would be worthwhile to get what we call germline tested. And I think that would be very important. I think I've had one patient who reported that her father died of some cancer and they weren't sure if it was appendix or not. And then when we did germline testing, there wasn't anything. Germline testing meaning heritable, something that goes in families. We didn't find anything. So I agree with Dr. Lambert that it's probably multifactorial.
Can I might add, we've got a series of 900 and some odd appendiceal tumors. We've got one father-son and one uncle-nephew combination. So this is not the kind of tumor that we see like a breast cancer or an ovarian cancer, which can go generation to generation to generation. It doesn't seem to have that sort of an inherited pattern that we see. I don't know what causes this. And usually what I explain to patients is I can talk to you about the genes that we commonly find that are mutated. Why they were mutated, I don't know. The short answer for why'd you get this is unfortunately still just bad luck.
Okay, great. Just one more point on that. We did have another patient that actually came up with twins. So one of the twins, maybe some of you have seen this, I don't know, it to me is pretty unique. So one of the twins, identical twins, had appendix cancer, and wondering should the other twin go ahead and have like a prophylactic appendectomy. I guess my answer would be, will a pay for it?
Yeah, I don't think there's any data to suggest that. I can certainly understand the emotional component to it. Again, it's such a simple, straightforward operation. It would be easy to do. Whether it would be covered by insurance, I don't know. As far as we know, her risk is the same as her siblings' risk was of getting appendiceal cancer, not an increased risk.
Okay, good. And then with prevention, I think we get a lot of questions about that. And so I think, Dr. Lambert, you pretty much have addressed that with things like exercise and diet. But I do wonder if our dietitian that we have has specific recommendations about diet do's and don'ts, both to prevent, but also we get this question in the context of preventing a recurrence. Is there something that could be done in terms of lifestyle that a patient could do to help improve their chances of not having a recurrence?
Sure, that's a great question. And I think one of the things that I get a lot is, what is the healthiest diet to follow as a cancer survivor? And one of the things that I look at is places like the American Cancer Society and the American Institute of Cancer Research. They've got really good specific recommendations. But I think the question that I always kind of help people go with is the Mediterranean diet is really showing a strong benefit in terms of kind of lifestyle and ease to implement. I think that one of the things that's great about the Mediterranean diet, it's also specific. lean proteins, whole grains, lots of fruits and vegetables. And I think the exercise component, every time I see it, it continues to go up. So I think as much as you can do is really the answer there. But it's somewhere between 120 to almost 240 minutes a week. So there's lots of great resources for survivorship. Yeah.
Great. Okay, good. So let's shift over to our kind of treatment bucket. One that we get lots and lots of questions on and all kinds of different forms. And I'll just throw this out. Maybe Dr. Levine, you want to start because you covered some of this in your presentation, but Dr. Turaga, I think everyone has covered this. So we'll just put it out there. But, you know, we get a lot of questions about Ipac versus Ipac versus even Ipac, which I know is a much newer kind of thing in the US and not really ready for prime time, but questions about what the current research shows. Is Ipac really still the recommended go-to? What is the difference between Ipac and Ipac? We get that quite a bit. I get, Dr. Levine, that was a really interesting presentation where then even within those questions, you have to get into specific agents, but let's not get into the agent question and just talk a little bit about Ipac versus Ipac versus Ipac. Any thoughts to offer on that? Let's start with what is the difference between Ipac and Ipac?
Certainly, thank you. So, a good question. The differences are Ipac is intraperitoneal chemotherapy, which is delivered into the abdomen and circulated around right after or during the operation. Epic, or EPIC, or early postoperative intraperitoneal chemotherapy, is delivered via catheters, which are left in the abdomen and delivered in the early postoperative period, either the first week or the first few months. The fluid is given into the abdomen as a dwell, and then some of it is drained out with the chemotherapy. You mentioned Ipac, P-I-P-E-C. That's really not available in the U.S. It's not been approved. It's not been approved, although there's some centers which are starting to work on it, and there's some trials which are in development. In Europe, this is done via a laparoscopic approach, where you put some laparoscopic ports in, those little 5-millimeter port cannulas, and then you pressurize the abdomen and deliver the chemotherapy as a fine mist under pressure into the abdomen. That's what Ipac is. So that's all ways to deliver the intraperitoneal chemotherapy. I think getting back to your first question, which is better, which is best, we don't know which one's better, which is best. The Ipac is experimental only, so I certainly wouldn't recommend that outside of a clinical trial. And to get it, you're going to have to go to Europe, which means you're going to have to go through all sorts of COVID precautions. I haven't recommended that to anybody yet. The Epic, there's a randomized trial which is going to be comparing Epic to Ipac, which is being done at Sloan Kettering. That's Dr. Garrett Nash is leading that trial. Each one of the Ipac and Epic, each one of them has got pluses and minuses, and that gets to be a long talk. Frankly, we could have a long symposium there. But I think the key question is, how much does the Ipac or the Epic do? And the answer is, we really don't know that well. There has yet to be a prospective randomized trial comparing aggressive cytoreduction with or without intraperitoneal adjuvants for appendiceal cancer. Of note, there was one which was just finished a couple of years ago for colon cancer, and I've spent my whole talk saying colon cancer is not appendix cancer, but that's the closest analogous that we have. And that showed that there was probably some effect, although that study was presented in 2018, and to date it has not been published in full manuscript format. And what that study showed is if you have really low PCI or low volume disease, or really high, it didn't make any difference if you did a Ipac or not. And there was probably some difference if you had an intermediate grade that could be completely removed. And again, you're asking me a really good question. To do that short, I think it's about as pressurized as I can make that answer. It's a difficult thing to do. We could have a whole symposium on that specific question alone.
Yeah. And we got so many, as I said, so many patients are asking those types of questions. So that was a really good, helpful, succinct answer. Thank you.
Can I just add one more thing?
Please, Dr. Lambert.
So I think my understanding right now is that Ipac is not done in the setting of cytoreductive surgery. So it's largely being done in the setting where people are not candidates for cytoreductive surgery. So it's just treating the cancer that's in the abdomen, and it's done multiple times, and it's not sort of an upfront treatment, right? It's if somebody has a recurrence or cancer that can't be surgically removed. So if there's an option for cytoreduction with either Ipac or Epic, I think we could safely say at this point that it's better than Ipac, which, like Dr. Levine said, isn't available in this country anyway. So.
Right. Good. Okay. Let's see here. Sticking with treatment, we get a lot of questions about this. This is probably for one of our oncologists. Chemotherapy. How do you determine really what is the type of chemotherapy for a particular patient? Is this based on pathologies? Is it disease burden? Like what goes into that? And we get this question a lot, especially with some of our other cancers like goblet cell and signet cell, but across the board, like how are those kind of chemotherapeutic regimens, those decisions based? Or is it just kind of a standard, go-to colorectal type regimen? Like what goes into that?
Yeah, I'm happy to start again. So it's actually a factor of all of those, right? Depends on the pathology. Certain pathologies don't respond well to chemotherapy. Others, like the signet ring, adenocarcinomas, those do respond. And so, I think more of chemo in that setting. Something like Lambert doesn't respond as well to chemo. There is a little bit of debate in there as well. So, it's a little patient-centric answer then. Which regimens? We do use a lot of the same as colon cancer type of regimen. So it's a 5-FU backbone with either both oxaliplatin and irinotecan or one or the other. And then we do try to use antibody-based therapy like EGFR therapy, bevacizumab in that setting. Who gets what and what combination? Our approach at University of Chicago is to be as aggressive as we can be for that patient to get a really good control of the disease, so that before we are subjecting them to a very large surgery, we have as good of a control of the disease as we can. So that's our approach. Then we start taking patient factors into account. Do I think the patient can tolerate a 4-drug regimen or a 3 or a 2-drug regimen? And that's how I make those decisions. It's certainly not one size fit all. Now, after that first initial, whether they get 1 line or 2 lines of therapy, it's still open. There's a lot of research needed in that space. If they've progressed on our first few lines of therapy, some patients do get, whatever is standard for 3rd line in colon cancer or 4th line in colon cancer, which are drugs like regorafenib or Lonsurf. We also start looking at novel ways to treat, clinical trials, whether it's using immuno, or targeted agents in that setting. And so that's how I approach. Happy to hear my colleagues.
Hi, this is Eloisa Soares. I'm one of the GI medical oncologists at Huntsman Cancer Institute at the University of Utah. Sorry, I had a slightly delay in joining. I agree with you. I think for patients with adenocarcinoma that are from appendiceal origin, for like more studies and personalized clinical trials, we tend to mimic, at least for the 1st and 2nd line, the approach that we have for colorectal cancer patients. And that's why pathology is so important, because there's so many different types of appendiceal cancers that will definitely be treated differently, such as neuroendocrine tumors of the appendiceal will be treated in a completely different approach. For the adenocarcinomas, I echo what you said.
Good. Anyone else on that? I know we're trying to move.
We're working on new ways and ideas, things like whether radiation could be a component in this setting. There are some ideas that we have that we're working with, trying to develop a trial in that setting, using immunotherapy for certain patients. Targets, there are trials underway, in the process of being opened that would help target more common mutations like the RAS mutations and things, and seeing if, you know, RAS itself or a combination could be helpful. And also the question of whether the KRAS G12C agent is in any way differently effective in appendix versus in colon, because they are different cancers. And so lots of, you know, kind of new research and ideas which is needed in this field, and we're working towards that.
Great. Just, okay, one more question in the treatment bucket, if I could put out there. And I think this one, and Dr. Lambert, please jump in and help me identify the right people. This one seems to be for the surgical oncologist. I don't know, I think Dr. Turaga is still with us. Maybe he can jump in here. But there are a lot of questions about surgical decisions with CRS, Ipac, and small bowel involvement, and kind of how those decisions are made, whether, you know, once the surgeon gets in there, is this still a candidate for CRS, for CRS Ipac? What's kind of the thinking about the of small bowel involvement that will affect those decisions, including kind of post-treatment quality of life sort of consideration?
I think that's a great question for Dr. Turaga.
I think, you know, it's, you know, we laugh mainly because I think it's a difficult situation for us as well. I don't think anyone has the right answer here. I think the big things are, of course, the overall picture, right? So the host, you know, what's the patient, what's the story, what is the disease biology, you know, is this a high-grade cancer, low-grade cancer? And I think those really help us determine what we can do. And I think there's technical pieces to this. So if you think about the bowel, you know, it's sort of like a hose pipe on a mesentery, which is sort of this blood supply of the intestines that comes from the aorta, which is the big vessel, you know, that comes from the heart, but that's in the back of the body. And so really you need the mesentery to be nicely splayed out, and that allows the intestines to kind of free float inside the abdomen and work and be effective and help absorb food. The problem becomes when cancers cause the mesentery to get completely involved, or if there's a lot of cancer on the surface of the small intestine wall called the serosa, it's very difficult for us as surgeons to remove all of that effectively. Now, there are techniques like mesenteric peritonectomies and things such as, you know, clearing all these things out. But it's, you know, still, it's probably one of the most technically challenging portion for us to make those decisions. I think, unfortunately, we don't have a playbook to say, you know, clearly this is someone where, you know, we could do something or not. But I think when we see things like mesenteric foreshortening, which means like the whole intestines are pulled into one little, you know, blob, and the cancer is a high-risk cancer, I think it's very difficult for us to completely remove that disease.
Yeah, Dr. Levine.
Sure. I mean, again, you could have a whole symposium on this, and this is a difficult question to answer. And unfortunately, it's one of those decisions that has to be made at the table. In addition to what Dr. Turaga is talking about, which is the mesentery, which is basically the blood supply to the blood vessels, if that's heavily diseased, that has to be removed, and there's a limit to what you can do there. The other thing is sometimes when this disease, even if it's low grade, is extensively involving the outside of the bowel, you have to resect it. A couple of things we know: once you've got less than 100 centimeters of small bowel left, you're pretty much going to be on IV nutrition or IV fluids for the rest of your life. There's no transplant that's coming from this, although the things have been explored in England. They've done a couple of transplants for this. And you have to judge what the quality of life is going to be with how much small bowel is going to be left. And one of the first things I teach my fellows to do when we start doing these procedures is evaluate the small bowel first if you can, because that's one of the turnback points. And as you heard in the radiology talk, frequently the imaging, CT or MR, notoriously undercalls how much disease is on the small bowel. So exactly how much is going to be left when you get everything cleared off is difficult. And there's a limit to how many times you can cut out pieces of bowel and sew it together. Once you have more than 2 anastomoses or 2 places where the bowel is sewn together, the morbidity of these operations goes way, way up. So you have to be cautious of that in terms of what you're doing. And all of this, as well as the issues that Dr. Turaga was talking about, go into the decisions of what you remove at the operation. And I would add that's one of the reasons why the learning curve for these procedures is so long. It takes some judgment, and you need to know exactly what you can save, what you can't, and what the implications are going to be for the patient over the long haul.
I think if I would add a small point to that, it's also, you know, in addition to the imaging undercalling how much disease there is, you also have no idea how adherent the disease is to the mesentery or the bowel itself. And so you really just don't know that until you're in there operating, which is why, unfortunately, when we have these talks preoperatively with patients, it's anything can happen, you know, from being able to take everything out to being able to take nothing out. And so that's, you know, I think a ripe area for, you know, research. If we could figure out a way to detect preoperatively how adherent things were, then we could have actually better informed conversation. But that's, again, something that hopefully down the line we can work on.
I would pretty much echo what everybody said, and Dr. Eng actually raises a really good point. You know, you have a sense of what you're getting into based on the imaging. I always warn people that the imaging is only going to underestimate what's there. We obviously expect to find more, or at least what we're seeing on the imaging, but that other component of it, you know, can we remove it? How invasive or sticky is it to be able to remove is part of the decision making. And I would just say that, and I think I can speak for my surgical colleagues, that this is one of the most difficult aspects of surgically treating this disease, is to get in there and think that you're going to be able to do a complete cytoreduction and find out that you can't. It's just devastating. And I know I personally spend a lot of time, like Dr. Levine said, just at the table, thinking and rethinking and looking and imagining and talking out loud to whoever's in the room. And unfortunately, it comes down to me because I'm the most senior and experienced person in the room. But because it's such a critical decision and so important, and so many things go into it, and experience is just something you can only get by being there for, you know, not so many cases.
Yeah. Good. Yeah. Thank you. Thank you for the candor, of course. So I'm going to put this question out. And I was thinking about this one. You know, it just seems like with the right patients, Ipac, CRS Ipac is such the right solution. But there, you know, people, obviously that's a very big procedure, and so a lot of patients have a lot of nervousness around that. And so one of the questions that we got was, is it true that Ipac causes internal organs to adhere to one another and to cause hernias and blockages? And just from a risk-benefit, pros cons perspective, can someone answer that for that patient? So can Ipac cause internal organs to adhere? I think of it more broadly, like what is the risk of that compared to maybe being eligible for CRS Ipac and foregoing it? You know, it's more of a risk benefit. But I don't want to editorialize.
I'll take a shot at that. The answer is yes, it can. Does the Ipac per se predispose you to hernias? Not so much that I know of. Any intra-abdominal operation done on the bowel has the potential of inducing adhesions and scar formations and hernias. So I don't know that it's so much the Ipac procedure per se. You have to keep in mind that many of these procedures are very extensive. So it's not like if you're just going to have your gallbladder out, you go in, you take your gallbladder out, you don't interact or manipulate the bowel much. You don't do a whole lot of removal or opening planes and exposing tissue that doesn't usually see scar tissue. So I think it depends on that. You have to keep that in mind. You're talking about extensive operations. And I think, although it is true that you can have that as a side effect, what I usually tell most patients is the worst side effect you're likely to encounter is tumor recurrence if the disease isn't appropriately treated the first time.
Good. Any other comments before we move into our post-treatment follow-up buckets? Okay, good. And let's see let's do a quick time check. Oh, good. We're about halfway through. That's awesome. You guys are great. So informative yet so succinct. So on the post-treatment follow-up, this, I think, do we still have, I can't see everybody that's here at once on my screen. Do we still have Dr. Medved or Armato with us? Because we do have a imaging question, but I can throw that out to the group.
It doesn't look like it.
Okay.
But throw it out there. Let's see if maybe
Throw it out. Okay, we'll throw it out.
do the best.
I like. There we go. So I think this was covered in their presentation, but maybe just in summation for those kind of dialing into bits and pieces today of this conference. Is there really a gold standard for post-treatment follow-up with respect to CT, MRI, tumor markers, and not just in terms of modality, but frequency and for what duration of time? Like, what is the best advice there?
I think I'd probably hand that over to Dr. Eng or Dr. Turaga, since they were so instrumental in putting forward the consensus guidelines.
All over yours, man.
Okay, sure. So, you know, I mean, I'll give all the credit to you for the guidelines, but, you know, certainly the surveillance, you know, if you are able to, hopefully we can distribute the guidelines out, and I think that'd be really helpful. But certainly, I think, you know, the surveillance is dependent on, you know, the etiology of the cancer, but typically it's going to mirror a lot of the surveillance that is done, you know, with other sort of gastrointestinal tract cancers like colon cancers. And so, but it definitely depends on, for example, the grade or aggressiveness of the cancer. So for the low grade, for the pseudomyxomas that are secondary to low grade appendicylomucinous neoplasms, you know, we do space out the imaging, at least initially, to every 6 months, to even every year, and then every 2 years after that, or greater, you know, because of the sort of indolent disease process that occurs. Whereas for some of the more high-grade disease, you know, post-treatment, our practice here is we actually get a post-operative CAT scan or MRI, usually sometimes even as early as 6 weeks post-operatively, but usually between 6 weeks and 3 months post-operatively, and then do that every 3 months of the first year, and then space it out thereafter to every 6 months and so forth. Because, you know, it's related to the timeline of the disease processes that are underlying each individual. And so, you know, if we are concerned that you have a more aggressive disease process, we will perform surveillance more frequently than not. And this is in conjunction with tumor markers and physical exams and so forth that help us, you know, give a better idea of, you know, of what's going on. You know, the reason for spacing out, for example, for more low-grade disease is because if you were to scan something more frequently, you're not going to see large changes in, you know, radiographically, and so, you know, there's really no benefit to you know, radiographic surveillance more often, unless obviously symptoms change and so forth. I don't know if Dr. Turaga has more to add with that.
I mean, I think, you know, I would echo most of those comments. I think that, you know, if it's high grade, we survey patients more often, low grade less often, certainly long duration of surveillance for the low grade patients. But I think the question, you know, many patients will ask is, you know, is MRI better? Is CT better? Is PET scan better? And the bottom line answer is they all suck. You know, I think that's the bottom line, which is that, you know, none of our imaging tests are good at detecting peritoneal recurrence. And we don't even know, you know, like sometimes we see mucin, sometimes we don't. And it's a tricky problem. So I think, you know, obviously you should rely on your center, you know, so whoever you're seeing, hopefully you choose someone that does this often enough, that they have enough expertise. And in the right hands, you know, the right tool can be very useful. So for CT has lots of advantages, MRI has lots of advantages, PET scans have some advantages. And I think, you know, it's just important to be able to use all that information. I think you heard from Dr. Lambert earlier this morning, and then Dr. Hay as well. You know, there's blood-based biopsy technologies, there's better imaging technologies. So I think, you know, hopefully in the next 2 or 3 years, we'll have better ways of identifying, you know, patients with disease. But I think, and I'd love to hear Dr. Levine and Dr. Lambert's thoughts as well. You know, like, we've also talked about concepts of laparoscopy, like you go back and take another look inside someone's peritoneum for early detection. But does that even make a difference? Like, are we finding out if is it going to be better or not? So I think we are at a loss right now, but it doesn't mean that we won't know the answers. And I think we need your partnerships, all of us, to work together to figure it out.
Laura, you're next.
Okay. Yeah, so I mean, I agree. There's no perfect study at this point. As Dr. Turaga said, there are definitely pluses and minuses to each of them. From a surgeon standpoint, at least speaking for myself, I know I can read a CT scan a lot better than I can read an MRI. And for surgical planning, for me, that is more helpful. There's been a lot in the literature about MRI being better with certain techniques, but you then have to have a dedicated abdominal MRIist who's interested in this problem, who's willing to put together the protocols and really follow people carefully. With laparoscopy, I do use it judiciously, again, meaning that, in the certain settings, if we're following somebody who's at high risk for recurrence and they're really anxious about that and worried that the imaging is going to underestimate what's going on, we'll often consider doing a diagnostic laparoscopy at a year or so after their diagnosis, just to confirm that the things that are what we're seeing on the CT scan or MRI are consistent with what's actually happening. I also use laparoscopy very frequently in the high-grade tumors prior to doing an exploratory laparotomy and cytoreduction, just to make sure that I feel confident that I'm going to be able to get all the tumor out at the time before I do a bigger incision. So there's definitely a time and place for it, I think. PET scan is a little less reliable, I think, in this disease. A lot of mucinous tumors, the PET scan just doesn't work very well for, but in the right circumstance, if we're worried about disease outside the abdomen, and we really want to get a handle on that, I think a PET scan is appropriate in the right setting. Ed?
Okay, so what you've heard is that we're already having a mini symposium on follow-up, and I think there's several aspects. There's some things that are right, some things that are clearly wrong. In terms of tumor markers, which is part of the question, we always measure them beforehand. If the tumor markers are normal before you start, the chance of having them go up, even in the setting of a recurrence, is extremely low. So if they're normal before you take the tumor out, I don't bother following them after surgery. In terms of the imaging, it depends on, is this a high-grade lesion? Is it a low-grade lesion? Low-grade lesions, I usually follow them every 6 months for the first 3 years, and then once a year through year 6, and then year 8 and 10. So usually for low-grade tumors, I'll follow these patients up for 10 years, and recurrences can come back many years later. The latest one I ever had was 17 years out. So it can happen happily. That's a rare event. For the higher grade lesions, it's going to be more difficult, and like Dr. Lambert, I'm better at reading CAT scans. They're available on this floor I'm on. MRIs are slightly more sensitive, but you also have to keep in mind, particularly if you're talking about the low-grade appendiceal or mucinous tumors, just because you find a small recurrence doesn't mean you have to go back and operate on it again. So being super aggressive in terms of finding very low volume asymptomatic recurrences in a reoperative setting, sometimes you're going to watch and wait on those. I've had patients wait decades, or things that they went on to pass away from something else. So just because you have a recurrence for some of these tumors does not mean you have to intervene. And some of these patients are going to be long-term survivors, even with disease. And if that's the case, then the reason to pursue aggressive imaging to find the earliest possible microscopic tumor disappears. So I think you're going to have to depend on a wide variety of issues, and then what's the best way to do it? It's going to depend on your center. I think you need to talk to whoever's doing your surgery and whoever's doing your surveillance. Great question.
I think there's also a practical aspect to all this. And I'm sure in Utah and North Carolina, patients travel from far away to seek treatment at these expert centers. And so, what I found is that the MRIs done somewhere else are often just of horrible quality. Whereas it's a little bit easier to get a CAT scan that's of acceptable quality somewhere else. And so there's that other aspect to this that, a lot of times patients live hours away. I'd rather them just get a CAT scan close to home rather than get an MRI that I just can't even interpret. So.
Okay, good. And before we move on, since there has been some discussion about recurrence, which obviously is always on patients' minds, What are there any particular symptoms that maybe a patient should be particularly cognizant of, in addition to doing their periodic imaging and lab tests? Are there physical symptoms that maybe they should be thinking about that might indicate recurrence? And I would imagine that's difficult following the surgery because many patients are going to have kind of post-surgical changes that are not indicative of recurrence, but could be, I'm sure, disturbing. Any thoughts on that?
I'll take a shot at that. I think the answer is, sadly, there's no specific symptom that you're going to find. The most common symptom with recurrence is no symptom at all. And it's going to be a very varied picture. By the time you develop symptoms, your recurrence is going to be relatively advanced most of the time. So the reason to get these imaging studies is to be able to find something before it causes substantial symptoms. The other thing that we know is that if you wait till the patients are having symptoms to take them back for a second or an iterative, you heard that part of a talk before, Ipac, the outcomes are worse. The worse the symptoms, the worse the outcome. So the idea is to get to the patients before they develop symptoms with your cross-sectional imaging and potentially supported by your tumor markers before you have those symptoms. When those symptoms occur, if you have them, those are most likely going to be related to GI, early satiety, changes in bowel habits.
Good. Okay, before we move into the research innovation bucket, since we have so many patients with, fears of or actual bowel obstructions, and maybe this is back to our dietitian, best practices to avoid that from a dietary standpoint, or maybe
Sure.
a standpoint, lifestyle?
There were actually a few questions in the Q&A section that I kind of noted, which is, struggling after the procedure and after getting your bowel back to kind of what is going to be the most normal for your bowel. And I did see some possible surgical interventions where people are going to have a little bit more short gut syndrome. And I think it's our practice to really try to get the person back to a near normal bowel pattern as possible. I think certainly after the procedure, we're actually doing a little bit of low fiber eating just to kind of get the bowel to kind of get reintroduction of fiber and nutrients. But then certainly at about 6 weeks, I know that Dr. Ng and Dr. Turaga are always, challenging me to get patients back to kind of a near normal diet as much as possible. So, and with, some of the Q&A questions, I certainly would encourage them to seek out an oncology dietitian, partly because there are some good medications that can certainly help with the diarrhea and make sure that you're not stooling or having less gas. And certainly, my thought is always trying to be getting you back to kind of a whole food diet as much as possible. But we know that that's not possible for everyone, but that's always the goal that we're seeking. And I just wanted to kind of also take that one last question about the patient, sort of towards the end of life care. And I think, here at the University of Chicago, we do use a lot of kind of central or total parenteral nutrition. If patients do have opportunities for clinical trials, we will be looking at, and I think that there's been a malignant bowel obstruction pathway that's gone on. And so we have a conversation usually to kind of talk about the need for parenteral nutrition if somebody does have a clinical option for treatment. So yeah, that's it. Thanks.
Thank you. And we do have several questions coming in through the written Q&A in addition to the pre-submit. So time permitting, I hope to still get to some of those, but let's see. So thank you very much for covering some of that up front. So research innovation, we get, and ACPMP Research Foundation has really been encouraging tissue samples and testing, genetic genomic mutation testing through some of the vendors out there that are offering this service. We get questions about what do you all think about that? I mean, are there certain mutations that might tell you about treatment options, about prognosis and outcomes? I mean, just in terms of we're in the research innovation space. So for example, we know something about KRAS, something about GNAS, but are there other mutations? Is there some research going on that, have identified other signals that may be important to determining or at least helping to inform treatment options?
And there's also a question in the chat in the live Q&A regarding how similar the mutation pathways are to colorectal cancer and the most common genetic mutations associated with appendiceal cancer. So maybe Ed, you could take that one.
Sure. The mutation pattern is similar but not identical. And the most common mutation, KRAS, is also very commonly mutated in colorectal cancer as well. GNAS less so. Some of the mutations, when you get the results back from these studies, the Foundation 1, the KRAS, or whichever version you use, there's a couple of aspects. Number one, we're looking for what they call actionable mutations, which is a mutation that we have a drug for that we can potentially leverage in terms of the treatment. Unfortunately, what we found is that there are very few of those. You're talking about less than 5%, even optimally viewed. So you may find a mutation. So the mutation has to be actionable, which is one of the words you'll hear. And I think the other word is driver. Is it a driver mutation? Just because you have a mutation in the gene that is mutated may or may not be important in the actual behavior of the tumor. So you want an actionable mutation and hopefully one which is also a driver. And unfortunately, the actionable driver mutations for appendiceal cancer are relatively few. They're not zero, but they're few, and they're more commonly seen in the high-grade tumors. Low-grade tumors, sadly, are very unusual to find something that's actually going to work. But I think I certainly invite our medical oncology colleagues to weigh in here.
Exactly.
I mean, I agree with what's been said. It's similar but not identical to colon cancer. There is more research needed in that area. We talked about KRAS mutations. I have seen one patient with BRAF, and there is a question whether the patient had colon or appendix. And so occasionally we see a patient like that could have been actually a cecal cancer rather than an appendix cancer for that particular patient. But we do check, and if we find something, sometimes I have to get creative in finding a drug for that patient to see if that would help, for example, PI3K. Sometimes we've been able to find, a treatment for them if there's nothing else and the patient has a good performance status and able to get more treatment. But it is an area that needs more research and resources, certainly to develop. Immunotherapy, there are certain trials at our institution that allow newer chemos or combination immunotherapies and allow appendix cancer patients onto that trial. So that's another area we are researching, and I don't have results to report. So that's to come.
Yeah, I wanted to emphasize that as well, that I think is worth it, particularly after someone progressed in the first, second line of treatments and you're running out of options, that is worth it to investigate further with whatever platform you want for NGS, because once in a while we might find something that is targetable. For instance, in PI3 kinase mutations are not seen that often. They're appendiceal, they're about only perhaps 10% of the cases, but if you do, you might consider targeting PI3 kinase pathway. And anecdotally, I have an example of a wonderful gentleman that was able to use everolimus and had initially a very nice response. Completely, this is not FDA approved, it was in sort of compassion use mechanisms, but I think if someone continues to have a great performance status, that the patient, the caregivers, and the physician feel that is pursuing further treatments is something that is worth it. I certainly would welcome investigation and give priority for a clinical trial if that's available over just compassion use. I think clinical trials for this disease are where we are have so limited options and it's so rare, I will 110% always encourage a clinical trial if we can.
And to that point, so the ACPMP, the Research Foundation now has started to cull through the clinicaltrials.gov database and identify clinical trials which appendix cancer patients may be eligible. Are there other ways to, do any of you have recommendations as to how patients, you know, can stay current with what clinical trial options are out there? Because unfortunately, what we find a lot of times is that for whatever reason, it may be they're not going to experts, I really don't know, but they're sort of on the ground physician isn't all that aware of what clinical trial options there may be, and unfortunately sometimes isn't all that helpful in pointing them in the right direction. And the clinicaltrials.gov database is a bit to navigate. That's why the foundation's trying to help out with that. But do you have any recommendations how to approach that with their team, or what they could do to stay current?
I mean, I think this is a challenge on both ends, you know, provider and patient ends. Patients find it hard to find and providers find it hard. I don't have a recommendation. What we do is we go through our trials, and sometimes I have to reach out to the sponsor to specifically say, you know, I have a patient who is eligible, has appendix cancer, would you allow? Many times they have allowed, they just haven't thought about it, you know.
Right.
But when they're putting the trial together for colon, let's say, or even a tissue agnostic, many times we are able to, but you know, I think that thinking needs to be challenged and modified.
Yeah.
I just want to complement that also when we're looking for clinical trials, we have to be realistic in terms of where we can go. So when my patients ask about clinical trials and their caregivers, I say, okay, if we find a trial, are you being able to move across the country to get the trial? So tell me where you have family or friends that if you were to find a trial, we can get you in and you have a way to stay long term, right? Because for most of these trials, there's very frequent visits, and you might have to consider to be relocating for 3-6 months and hopefully for a year or two if the treatment works extremely well. So what I do, I ask my patients that question, they come back, they talk with the family, they try to figure out that, and then they come back to me, and then I call my colleagues on these institutions and check. Or if I don't call, I found that connecting via social media without sharing any private information from the patients, just to connect. We might not have the emails of our colleagues that quickly handy, but we certainly can find them on Twitter, for example. And I have been able to connect my patients with other institutions using this and get them in for clinical trials. So I think patients have to be their best advocates and remind the oncologists, and then have this honest conversation with the oncologist of where they can really go. And then from there, the oncologist should be the champion trying to help the patient to find a trial. That's my personal opinion.
Good. Okay, good. So quick time check. I think we have, if my watch is correct, we've got about 5 minutes. We have more questions than we have time, but we anticipated that. I think if there is time after each of the regional breakouts, we're going to try to get to a little bit more Q&A with the moderators there. Boy, we still have so many good questions, and we have some coming in through the Q&A. I think many have been answered already in writing, so that's good. If I could, what I'd like to do with the remaining 4 minutes that we have is end on a high note, because I think that after listening to all the presentations and all of your expertise, and I mean, there's so much hope that I'm hearing as a caregiver in this space. And so I'd love to hear, we get questions, and we got a lot here about prognosis and outcomes, and is this something that really people can go on and have extended life with and quality of life. So even I think Dr. Levine, you touched on this, even in the face of a recurrence. So let's just do a quick round the horn for anyone that wants to raise their hand, and any words of hope or encouragement that you have for patients, I think would be a great way to end this.
I think, should we get Dr. McQuellon in here to comment? He's sort of the expert on quality of life after cytoreduction and Ipac. Is he available?
I think he's having some connection problems. I think one thing I can tell you, I know he would say, because I've worked with Dr. McQuellon a lot, he said there's always hope.
Always hope.
Other kind of in the research frontier, or what? I mean,
all right, so I'll throw something out as the moderator with the most gray hair at the table. I can tell you we've learned more about appendiceal cancer in the first 3 years than I learned in the first 25 years of my career. We finally have genetics which are beginning to pick apart the tumor. Our understandings of how it works, what makes it tick, are finally beginning to come unraveled a little bit, and I'm hoping they're going to give us ever more important insights in terms of how to treat the disease, in addition to Ipac. And Ipac is a wonderful tool. It's not the only tool. It comes at a great cost. And when I talk about cost, I'm not even talking about the dollar cost. The personal cost, as we've heard, in terms of quality of life for the caregivers, is substantial, is enormous. And even with that enormous undertaking, it's not always successful. So we need additional help beyond what we can do with even the most aggressive surgical operations. And we're looking at it. I hope what you've heard today is a number of research approaches. You know, we're working on it. This is a rare disease. Some would call it an orphan disease. And I've heard that phrase. I really hate it. None of my patients are orphans, okay? They are here. We are here to help you. And we are working to make the treatment better, not just with the surgery, but overall. And thanks, everyone, for being here, if I could add that.
And Deb, maybe we could get Sarah to weigh in. So Sarah's a physical therapist at the University of Chicago, and I think she can probably comment on the quality of life issues and things that people can do to help in that regard.
Yeah, absolutely. It's one of the challenging things is, of course, the function level and the fatigue that's often associated, especially with this massive surgery. And a lot of focus that we have for our patients that we see in Dr. Turaga and Dr. Ng's clinic is trying to improve that function back, improving their quality of life with returning back to whether it's work or day-to-day tasks or things that they found joy in before, whether it was an exercise program or walking or being able to socialize and take care of their grandkids. So, we take those personal aspects of their life into consideration, and also looking to it, especially because of where surgery is and how it impacts pelvic floor function, making sure, Jeffrey had talked before about the diarrhea aspect, but, we're also looking at the muscle aspect as well. And do people have control, and what else, how does that impact their lives? So, we at least trying to make sure that the person is taken care of from physical and nutritional and obviously that emotional being as well in Dr. Turaga and Dr. Ng's clinic.
Good. Anyone else before we wrap up our discussion session? I see we're right on time.
I just want to thank everybody, mostly our patients, actually, for inspiring us and keeping us grounded and motivating us to do more. Thank you for this opportunity as well.
And I would just echo that about the patients. I had a powerful experience in clinic this week where one of my patients commented that he's living on hope, and the more hope that we can provide, the better for them. And so I'm really hoping that people are finding that here. Recognizing that you're not alone, that there are a number of very dedicated people to this problem, not just the surgeons and medical oncologists and other providers who are here, but we have a wonderful community of Ipac surgeons and dedicated medical oncologists and pathologists who are really trying to solve this problem and make things better and understand it better. So there is hope. We're here for you. You're not alone.
That's a great way to end the Q&A session and turn it back to you all for closing remarks. I just want to thank all the panelists for your candor and the time and really taking up as many questions as you have and giving your expertise. So thank you very much.
I just want to add in here real quick before we wrap up, a big thank you to everyone for submitting questions, and thank you to our amazing panel for answering them all so thoughtfully. We definitely had way more questions than we were able to get to today, so we really apologize if yours was not addressed. But please stay tuned. We are going to do a quick wrap up of this general session with all three of the main doctors to close out. And if you are planning on joining one of the regional programs that begins at 3 o'clock, please stay tuned for details on how to join in on those. And if you did not end up registering for one of them, but you do want to join in on one of them, we will be including all of the links in the chat after the closing. So please stay tuned for that. Thank you again to the panelists, and thank you for everyone for submitting questions. And with that, I will also turn it over to Dr. Lambert, Dr. Levine, and Dr. Turaga to close out this general session. And then I will just pop on again really quickly to reiterate that the links will be in the chat.
Great, thank you, Lauren. Ed, do you want to summarize anything?
Sure. Well, I think for the people who have joined us, again, thank you for joining us. There is always hope. We have a lot of people who are working to make things better. The one thing that I guess didn't get said in the last 5 minutes is I would encourage you to support the ACPMP. We would not be here talking right now if it wasn't for their efforts. And what you have there is an indefatigable group of people who are really motivated to help make this disease go away. So thank you to them. To put this together has been an enormous amount of work. Thank you for helping us out during a COVID pandemic. And as challenging as it is to have cancer, I will tell you it is even more challenging to have cancer during a pandemic. So thank you to everyone. Thank you for everybody in the ACPMP. Support the ACPMP. And they have continued to support appendiceal cancer research as very few, and frankly, as nobody else I know of has.
I would also echo the thanks to ACPMP, to all of you. I think one of the folks and groups that have not been represented are all our colleagues across the country. I've seen some emails or questions about surgeons or centers not being represented at the symposium. Please note that that doesn't mean that they're not advocating for you or fighting with us hand in hand. I think it's it's just logistically how I think the three of us got together to bring the symposium together. But I think all of us in this community of peritoneal disease, we're very soul-minded in trying to help our patients get better. And I think there was also a question in the chat about the fact that if this is a rare cancer, shouldn't it make for better treatments and better cohorts and better clinical trials? And the answer is yes, but it requires advocacy and fundraising. I mean, there is no way that any disease will, Ipac, is difficult to get covered by insurance companies. There aren't drug companies seeking to find better treatments for this. And so really right now, we rely on your energy and support and ours and organizations like ACPMP that will help us advance the field. And I'm also very thankful to my colleagues. I think everyone, obviously from all the three institutions who have taken the time, but I think more importantly, showcase, years of their experience and work that they've put together in helping combat the disease.
And I would just kind of follow up and echo what's already been said. I just want to absolutely thank all the folks at ACPMP for their hard work, their effort. It's been fun to watch the foundation evolve, and just to see how much money they've raised, how much awareness they've raised, to have them come to our meetings and be a part of that, to see them connect people. And now with the patient registry, we're really excited about that as well. And I just also want to echo what Dr. Turaga said. There's a whole community of surgical oncologists who do the HIPEC surgery and have a real interest in fighting this disease. They're wonderful colleagues, and I'm so grateful to work with them. And just again, I think a question came up in the chat about how alone are we, how many people were on. I think I saw close to 200 attendees at one point. And I know there were something like 400 who registered. So you are not alone. I hope that this symposium has helped you feel that as well. And just thank you again for attending.